Welcome to the Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. Eric Makhni. Dr. Makhni is a sports medicine orthopedic surgeon at Henry Ford Health in Detroit Metro, Michigan, and team physician for the Detroit Lions. At Henry Ford Health, Dr. Makhni currently serves as the Senior Clinical Advisor for Patient-Reported Outcome Measures and the Director for Orthopedic Quality and Informatics. From this work, he launched Protera Health, a joint venture with the health system. Protera Health partners with health plans, providers, and employers to improve musculoskeletal health by personalizing care journeys according to patient-centered data. Dr. Makhni completed his undergraduate degree at MIT, followed by a combined MD and MBA at Harvard. His orthopedic surgery training was at Columbia University in New York City, followed by a fellowship in shoulder and sports medicine orthopedic surgery at Rush University in Chicago. Dr. Makhni, Eric, welcome to the show.
I'm very excited to be here. Thanks so much, guys.
It is amazing having you on. You've led such an inspiring and dedicated career that's really focused around the patients, whether it's exceptional orthopedic care or your extensive clinical body of research on sports medicine, PROs, and solutions that can greater impact that scale patients, as well as giving back to the community in various ways. I'm really curious to start the conversation, like what drew you initially to sports medicine and orthopedics?
Yeah, it's actually a really good question, and we don't get asked that often. My parents are physicians. So my mom's a primary care doc, my dad's a cardiologist. They had a practice together. So growing up, I would always visit them. And so my view of medicine as a kid was just office. In that office, it was primary care. And I didn't know my dad did as a cardiologist, but I just knew that was primary care. And as I learned more about cardiology and about surgery, I remember shadowing my dad's buddies who were open heart surgeons and seeing bypass, like, this was when I was, I don't know, back in the early 90s or maybe mid 90s, seeing open heart surgeries by the anesthesia, seeing all the bypass, everything was unopened. And I was like, okay, I want to do this. And so I requested to volunteer at our hospital to work in the ER where all the stuff was going down. And they ran out of space in the ER. And they're like, I was devastated. I was by like ninth grade. I was devastated that I couldn't get this volunteer job in the ER. And they sent me to the physical therapy ward. And I had no idea what that was about. And so I was like the ice bucket boy. I would fill people's ice boxes up while they were recovering from other surgeries. And that's when I started to see about sports medicine, joint replacement, learning what people, these are patients that were like motivated. They were not all super obese and bad cholesterol. They were trying to get back to play sports. I played college tennis, so I grew up playing sports. And that's what got me into orthopedics and sports medicine. So I basically was hooked on sports medicine since I was 16. There was a period of time when Nip Tuck came out that I thought I wanted to be a plastic surgeon. And then I saw all the craziness in that show and I wanted no part of it. And so it's basically been a weird focus of mine in sports medicine.
So your brother, Melvin, is also an orthopedic surgeon. So you both ended up in orthopedics. Like, what's the story around him?
Yeah.
He also volunteer on the same physiotherapy ward?
So my brother's 2 years younger. He's a spine surgeon and a cervical spine specialist at the Brigham at Harvard. And we played tennis together in college on the tennis team. So we did high school together, college together. We were the same fraternity in college. We did med school. He did the MD MBA as well. We were in the same residency, and we finally diverged at fellowship when we both got to be 32. So he went to spine, and I was sports all the way. So he's a smarter than the two of us.
That's really funny.
Well, so speaking of being smart, most physicians, they go and get their MBA later in life, and you actually got yours kind of concurrently with medical school. And so I was wondering, what's the thinking behind getting an MBA so early? And what have been maybe some of the benefits for you as a physician leader over time?
Yeah, that's a really good question. I got the MBA, I was class of 2010. And I applied to the program around 07 or something like that, And so at MIT, the biology track, it's actually relatively short. And so I actually was in a situation where I could have finished in 3 years. But I decided to do a fourth year. My parents always struggled with the financial part of medicine. They got beat up a lot on that because that was when the EMRs were starting to get mandated. They had a practice of 2, right? To have a private practice of 2 docs now is like, that's hard as it is now. And then think of the transition. So my parents really encouraged me to take business classes. So as a senior, I started taking a bunch of stuff in microeconomics, macro, organizational behavior, optimization, negotiations, finance 1, finance 2. And so I already knew I wanted to understand the business world and the business of healthcare. Well, Harvard was one of the first programs that I was aware of that did a streamlined path of 5 years. So it was for the way they did it was really nice. And I almost didn't apply because back then, and probably still a little bit now, but not as much, being an MBA in medicine was looked down on, right? It meant that you weren't clinically hardcore. And I remember the first several papers I published, I didn't put the MBA on it. I just put Eric Makhni, MD. I didn't want to give the wrong impression that it wasn't hardcore clinical. And so I waited to the last application cycle to apply to the business school because I had already done a lot of the coursework. So I was like, I kind of know it. And so I'm obviously very happy I did. But it was a time when my mentor in med school also did not put his MBA on his papers. And so that was what did it. When I finally was like, look, there's enough good in this. I'll do my own thing clinically and prove myself. And that's kind of how it started. But the program there was very good, very cutting edge. Back then, only 13 of the 150 students applied. And now I think shortly afterwards, it got very oversubscribed. And so they were turning people away, but it was a great time to do it. And it was almost like a full MBA experience, like a full-time immersion. That was great.
How has that changed like the way you practice medicine today? Like, are you a lot more aware of like cost structures in your clinical practice or things like that? Or how do you think you do things differently than folks who haven't done an MBA in medicine?
Yeah, I think there's two parts to that. So the MBA, what's crazy is that like now that I've started my own company and I'm reaching out to folks, people always just say, oh, it's for the networking. I never bought into that. Wow, is it true? Like the people who we hung out with are all like, I mean, I'm re-engaged them now and they're all doing crazy things as leaders of different companies and startups and big healthcare payers. Like some of my colleagues and friends are like big shots in these companies. And so I think that, the stuff you learn in the books is fine, but it's like everything, like, we learned organic chemistry. Like how much of that do we use now? So I think business school, first and foremost, just exposed me to a world that was outside medicine. And in medicine, we spent all day focusing on things like the Krebs cycle, glycolysis, organic chemistry structures, stuff that's totally irrelevant and very microscopic, literally microscopic, atom level. And we lose the forest for the trees on like what happens if a patient can't afford medication? What does it matter what the medication does, right? Or how do you deliver care? How do you actually make it financially viable or align incentives? And I think that part of it you do learn in the business school. I also learned a lot about venture capital. That's what I wanted to focus on, and innovation, entrepreneurship. On the other side of that coin, though, is actually was in college at MIT, and it's not certainly unique to MIT, but it is very characteristic of that place, is that at school, there were people that started companies like 22, 23, 24, and big companies, right? Like the Dropbox and all those. So Facebook, we were the fourth school in that. So, with contemporaries down the street. And what you learn in an atmosphere like that is that anything's possible, right? It is totally normal to say, hey, listen, I've got a great job. I'm my 7th year in practice. I'm making a lot of money. Let me go ahead and risk a lot of that and start a company that I don't know if it's going to work, because it could work. And I think we could do something really cool. And I think being surrounded by that mentality of, yeah, why not try it out? Why not try to build something? Why not try to take a risk? That I think has shaped my thinking very heavily. And again, I don't think it's unique to where I went to school, but it is, I think that's even had more of a mark on me than the MBA, but they're both very relevant.
I think that the network piece is such a great point. I mean, when people ask me like, hey, Josh, like, should I join this like accelerator or some sort of like incubator program? And I always tell them, hey, forget whatever the curriculum is in these programs, look at who the mentors and the alumni are, because the network is really what you're getting out of it. And if you like what you see in like the mentors or the alumni, like great, do the program, but like don't even look at the curriculum. That's not really going to be the value out of it at the end of the day. So like, I totally agree with you on that.
Yeah. And you don't even know what you're going to come your way or what door's going to open. Or, I mean, even with you, Josh, it was on, I started getting a little more active on Twitter, or just at least we're consuming it. And you reach out to somebody, and a lot of people, well, it's funny. It's like, the higher up the food chain I get, the totem pole I get in my professional life, like the lower I feel, because like I'll reach out to folks on LinkedIn or Twitter or cold reach out, and like I'll have 23-year-olds not return my call. And usually as a surgeon, we're kind of used to people more inbound. But doing this whole startup thing, it's like it's just another step. Whereas the higher I get, the lower I feel. But you reach out to some folks, and then you will resonate. Like that's how we connected, and here we are today. And I've picked your brain on a bunch of stuff. And I think that networking mentality, if you just, and what else is interesting is that with networking, and then this, both of you guys know this full well. Like we always think of networking as like, what can we get out of it? And those who do it well, and I'm not saying I'm there yet, but the more you like help, the more it just comes back 10x. And I think that is also something that it's certainly not like explicitly ingrained in college or business school, but it's something that I think people learn with time.
So many great points. If we could just unpack a couple real quick. So one is, I forgot to mention, so Eric and I actually met through Twitter. So I think you're actually the first guest we've had that happened because of Twitter. I don't know, Alan, if I'm misremembering someone, but I think this is the first time.
Yeah, I reached out to you several months ago. I'm like, oh, this is an MD founder of a company that seems to be actually like with a product and sales, and they're doing something. So I should probably reach out and see if we can get some advice. And it's funny, like I called my brother today because he's my co-founder, and I'm like, hey, listen, I met a new guy on Twitter, and he's like, congratulations. I'm like, because he hears me say it all the time now, like that. I'm just calling like random people and seeing who we're trying to call and see if we can start a conversation and see if there's some synergy or compliment. Everyone's in the same rat race and admittedly very different parts, but
totally. So I love the Twitter story, and I love your second point about just like code calling and having humility to just like randomly contact people and just see what serendipity happens. And I'll share a quick story that actually your story reminds me of. So when we were raising our seed round maybe 7 years ago, I didn't really know that many investors. Like I didn't have a lot of folks who could introduce me and refer me and all that. So I was going down LinkedIn, Google search AngelList. I'm looking up physicians who angel invested and just randomly contacting physicians. And I met one surgeon who actually met with me and said, that's really not up my alley. And I said, no problem, that's fine. And then a week later, out of the blue, he emails me saying, I was talking to my brother, who's also a surgeon, and telling him about your company. And he was actually a lot more interested than I am.
Yeah.
So I'm going to connect you to him. I'm like, oh, great. And so I met his brother. And like after 30 minutes, he was like, oh my gosh, like this is the future. I'm going to invest. And who would have known that it was the brother of a guy I randomly code contacted?
Yeah, I need more of those phone calls coming in. So, but it's funny because I, as a health system leader, right, overseeing a lot of these initiatives, I'm the person on the other table where the inbound of vendors is like, it's like an onslaught. It's all the time. And before I would just ignore them. I would just be like, whatever. And now like I feel the pain because obviously you start in a company, you're in sales. That's what it is for a long time. So now I respond to almost as much as I can every inbound and say, look, I'm not the right person, but here's a person to talk to. And if it's compelling enough, I'll just make the warm intro because I get it's this kind of blind faith in karma that the gods will bestow upon me back if I keep doing this. So I try to help, but it's funny because I've always been on the other side listening to these pitches and seeing these slide decks of these 8x ROI in 6 months and all this stuff. And now I'm trying to figure out how to be on the other side of it.
You have way more empathy now being
So
on the
much.
other side of the table. That's fascinating. Very true. Yeah.
100%. And acting like a sponge, right? Like learning from everything, every person that you're encountering, every cold call that you make and taking that knowledge back with you, gaining more empathy. That's awesome. Eric, following the first wave of COVID, you took on additional responsibilities as the Director of Quality and Informatics for the orthopedics line at Henry Ford Health. I'm curious, what drove you down that path and why around that time?
So a lot of folks aren't familiar with the concept of a service line. And admittedly, I'm still relatively young in my understanding of how these service lines really function best. But in essence, at Henry Ford Health, we have basically 5 hospitals, each kind of relatively distinct. And over the last several years, they've come into become a service line where the orthopedic service line, at least from an orthopedic perspective, the goal is to try to standardize as much care as possible to promote quality, cost savings, financial performance, skill development, whatever it is. And that service line was coming about, 2019, I think. And so there was this need to look at data outside the confines of a single hospital and look across 5 hospitals. I think we have 135 providers between surgeons, non-surgeon physicians, and advanced practice providers. I had been looking into patient-reported outcomes since 2014, studying them as a research tool, as a quality tool, as a decision-making tool. And so how we got started in patient-reported outcomes was basically, that was what I was working on, was trying to get that so that we had these outcome tools for patients when we make decisions. And so it was a natural evolution of taking on more responsibility and moving out of when I started at Henry Ford, I was 20% clinical research, 80% clinician. That 20% FTE protection was a vehicle for me to say, let me do something that's a little different from research, but still rooted in the scientific principles of care delivery. And so that's how that came about. And quality at the time as a new service line, like these quality measures, even basics like mortality, right? We needed someone that would like hone in, really look at mortality. And what we found was that like, just by looking at it, we realized that if there's a few patients that were coded incorrectly, or let's say they came in with a tibia fracture and also had a heart attack and then died from the heart attack, just fixing the coding to more appropriateness actually was a huge driver of performance and more appropriateness, right? So we needed someone to really dive in, and that's kind of how that all evolved.
Can I ask you, like, I know we're going to get into PROs. That's one of your expertises, but we've seen way more progress with PROs and PROMs in orthopedics than I think any other specialty in medicine. I'm wondering if you have any insight into like, why is that? Like, what has orthopedics figured out, or what's motivated orthopedics in a way that we just haven't seen any other specialties when it comes to PROs and PROMs?
So I was doing a lot of research in hand surgery as a medical student. That was my mentor, and he was phenomenally. I work with him today. He's at Henry Ford, and he's a hand surgeon. So I did hand research. And if you look at the outcome scores, again, this would be 2005, 2010, when I was doing these research studies, a lot of people were using things like the Gartland and Worley score, which is a physician-derived score that said, okay, what does the X-ray look like? What does the deformity look like? Okay. Subjective, how bad is the patient in pain? Let's give them a score of excellent, good, fair, or poor. And that's our score. Well, you can have somebody with a horrible deformity be perfectly fine, right? Like a 75-year-old woman with a wrist deformity, I mean, almost not even notice it. And so I think the field started evolving, understanding that like these tools are not they should not be physician-derived metrics. They should be patient-derived metrics. And a big part of orthopedics are joint replacements, right? You have a very reproducible surgery that's done on the masses, whatever, millions a year, and you can be really quality focused on that reproducible amount. And with orthopedics, the big drivers of outcomes are pain and function improvement, right? And so that, I think, and then a lot of orthopedic surgeons are quantitative, numbers driven, like that's just how we think. And so I think that whole melting pot, what led to things like big registries in Europe, right? Those Scandinavian registries, the Danish registries, the European registries on joint replacement, really taking PROMs and really centralizing care on them and outcomes on them. So I think that's why orthopedics has done that. And then the cornerstone of research is PROMs, right? And I think a lot of my effort has been trying to figure out how to take PROMs out of a research tool, which admittedly 99% of surgeons don't do, and make it a clinical tool. And that's kind of where that how process started.
Maybe to unpack a little bit, what do you think has to change in the environment so that more and more surgeons switch from it being purely a research tool to more, at least a quality improvement or a data care tool?
So for the last several years, we have threatened, anytime I give a talk, like PROMs are going to get you, you better measure them or you're going to have to be forced to measure them, and measuring them is not easy, right? That's whatever the last several years of research has been on that. And two things needed to happen. One was that insurance would mandate it. And CMS in their new 2023 inpatient rule proposal for hip and knee replacements, and admittedly a small proportion, just the inpatient, have now laid the map and the groundwork for requirement of patient-reported outcome measures. And the essence is that they have to collect PROMs pre-op and 1 year post-op. The second thing that and then we know if CMS does it, the payers are just going to do it, right? And no one's paying the clinicians or the systems to help collect them, even though there's a cost to doing so. It's just like, you got to figure it out. Fine. The second thing is which hasn't happened, is if there's just a CPT code. Yeah. If you just like my mentor, Kevin Bozek, who's one of the big players in value-based care orthopedics, he always says, I don't know if this is his original saying or if he got it from somewhere else, but if you go to an orthopedic clinic, we have no problem lining every patient up, putting them on a cold metal slab, irradiating them for an x-ray that they may or may not need, and not seeing a patient until that x-ray is done, right? For elective surgeons, the x-ray doesn't matter, right? You can have somebody with bone-on-bone arthritis, but if their function is normal, they do not need a surgery, right? They just don't need it. Maybe some do, but most do not. And CMS has adopted that, right? That's what they're looking at these scores. And so, but to do a 2-minute health assessment for physical, mental, and pain health, whoa, that's I don't have time for that. Or to understand if a patient has active untreated depression. I don't care if that leads to a 20% higher complication rate. I don't have time for that. And so what happens is the EMRs have not built that in, right? There are major EMRs, which I'm not going to call out, but major ones that you cannot measure PROMs on in any sort of high fidelity. When those two things change, and one has already changed, now the EMRs have to follow suit, right? If the EMRs, which we all live in and depend on, allow for problem collection, it'll be part of care, right? And again, if somebody sees me for a meniscus tear, I'm a sports medicine surgeon, right? So meniscus tear, rotator cuff tear, nothing like acute or functional. I mean, if they're doing fine on an objective measure, like I don't need to do anything. They don't even see me. Just go home, do some exercises, and live your life. You're fine. And so we're starting to understand that this is really important, but the IT infrastructure and the integration has to get there. And it's starting. And one of those two dominoes have already fallen.
I think that's a fantastic point where like you're getting at like, how do you reduce the friction to doing something as part of standard clinical care? Part of it definitely is like our current IT systems like the EHR have to make it easy for it to be part of your workflow. Part of the research that you've done on PROs, are there kind of like one or two strategies you've found that even outside the EHR where you're still having to somehow collect them, one or two strategies you found to increase adoption or response rates? Anything that's worked out well for you?
And I will say a lot of what I've done in PROMs and PROs has been built on the foundation of folks like Dr. Judy Baumhauer from Rochester. I kind of just copied what she did, maybe a little differently because we have a different institution, but I kind of copied her. And so I'm going to give a lot of credit to her on this. The one thing she always says is that the process has to be invisible. So on an average Monday morning, I might see from 8 a.m. to 1 p.m., 30 to 35 to 36 patients, right? My PROM collection rate, and we do about 3 to 4 PROMs per patient, is about 90-something%, right? And I'm not atypical in my system. I have patients, docs that see as many as I do, if not more, and they're still in the high 90s. It's because the process is invisible. To be invisible, it's got to be fully integrated into clinical and IT workflows, and it's got to take less than a few minutes because there's no wait time. You're just going in quick. The second part of it is the data has to be available in real time. I have to have the data in front of me when I look at the patient, right? Yeah. If I'm judging an elective surgery, like a non-structural surgery, like a meniscus tear or a rotator cuff tear, if it's not causing a lot of functional issues, knee replacement's one, right? We need to see that data in real time, and we have to engage the patient with it. Those are two things that have to happen. If you have those, you'll use it. And then there's a whole kinds of other quality improvement tracking you can do to make sure docs are using them. But those are two cornerstones. After that, everything is nice to have.
Yeah. And I know, Eric, you've been an advocate for automation in PROs to make them seemingly invisible with the workflow. I think one of the steps in your workflow is even on the patient intake form, you're introducing that very first PRO, which I think is phenomenal and such a great way to weave it into the clinical care.
Yeah, that was an idea our CMIO, Dr. David Allard had. And, you know, we go to conferences and some practices will say, we're having trouble with PROMs because the patient has a clipboard for the intake form, like how'd you get hurt? What's your VAS score? Do you smoke, drink, workers' comp? And then the PROMs. And the key is it should just be one process, right? Make the intake form a PROM. And at Ford, we actually looked at the intake forms and we have, let's say in our main medical group, about 30 or 40 surgeons. Each surgeon had their own intake form, 3 or 4 pages long. And some had review of systems because that was important back then for billing, pre-2021 or something. And some docs had different intake forms depending on the different clinic. So the front desk was photocopying 4 or 5 pages for each patient for their new patient visits. So what happened is that our PROM infrastructure lives and dies with our front desk, who does not report to us. They're a different operating unit. They don't report to orthopedics. They don't have to do anything we ask them to do. But by making it easier for them, it becomes sticky because if we don't use this process, then they've got to go back to photocopying. And the intake form, if you look at it, there's a couple different flavors, but everyone asks pretty much the same questions. So we just switched it on overnight and our department's been awesome and everyone's just bought into it. The other nice thing is that from an operational perspective, if you're seeing lots of patients, you're not doing your notes right away in real time. And so either you have to write down notes like, oh, this is Joe Schmo, 16-year-old with knee pain that hit it on the football field, or the intake form says, I'm Joe Schmo. My injury was in football getting tackled. It happened on January 28th, 2023. My pain score is 5. I don't smoke, I don't drink. And then you make it automatic into documentation. So when I do a new patient notes, it automatically flows that information in. Now you make it sticky for clinicians. I have some clinicians who are like, I don't care about the PROMs. I need that intake form automatically fed in. Right. And so I think that's what I've been really focusing on is how can we make PROMs a useful operational tool and a useful clinical tool rather than something we put in the doldrums of research lakes that we pull up for whatever we want to later.
Yeah, that's great.
That's a fantastic insight. It's like basically add so much value from the PROMs into the clinician workflow and then they can't live without it.
Yeah. And we've got, like I said, we've probably collected almost 900,000 data points so far in a few years. In our service line, we have screened over 100,000 patient visits for depression. in orthopedics, right? I mean, that's kind of wild. We do a PHQ-2 on every patient. We used to do a PROM suppression. And what's crazy to me is that like in the beginning, I was, really managing it and making sure the compliance was good. And our goal ambitiously was to be at above 80%. And we stuck there. And we got populations that are very elderly that don't use technology or don't speak English, right? And it's a very diverse metropolitan area. But I think the stickiness has helped us, and the invisibility has helped us stay on a cruise control and not needing babysitting the whole time.
Amazing. Good segue to, and what I love is actually your story makes a lot of sense from a narrative point of view. So, you had this incredible expertise in PROs and PROMs. And then more recently, you were motivated to take the expertise and start this new startup called Protera Health, where you're using a PROM-driven, data-centric approach to help guide patients to more appropriate and cost-effective care. Love to learn more about the origin story for Protera Health and what you're hoping to accomplish.
Yeah, as a little backdrop, when I was in college, I entered the MIT 50K competition a few times. I can't remember everything I submitted, but like a couple of times we got to be, I'm advanced one round. It wasn't chatting. But I remember submitting the idea for a kind of ZocDoc type top physician marketplace in 2005, because I was a first year medical student. And then in residency, we started an online physical therapy company in 2012. The big MSK digital companies actually came around in 15 and 16. So I've always tried, and in med school, we started a company called Money for Study where, we were walking into the med school and it's like, get paid $50 to do an MRI of your brain or get paid $3,000 to do a sleep study. So we made a website that could collate all that. But each time I tried to start a company, I didn't have the financial means or the time means to really work on it. We had a company, PhysiLife, that was a physical therapy company. And we didn't know, we filmed all these physical therapy videos and we didn't know who the customer was. I was a resident at the time. I had no connections. I was a third-year resident and no money. And so we were trying to pitch this to physical therapy companies. And we actually became a finalist in the Harvard Business School alumni competition for New York on it. And I didn't know, we didn't know what we were doing. And so I think that now that I've gotten more expertise on PROMs and how we could democratize these tools, and also more connections in value-based care and understanding of value-based care, I think I may have a little better insight into where this can go as a company. And so Protera Health was basically looking at the clinical transformation of Henry Ford and saying, can we democratize this? In our primary care sports medicine physicians, we have about 5 or 6 of them. We did a survey and 100% of them look at PROM scores before they refer a patient to a surgery. Yeah. That is probably the most proud of anything I've done. And 80% of our surgeons say they look at PROM scores before they decide for surgery. Not all time, but sometimes. And I think that is moving the needle. And I don't know how many unnecessary surgeries we've prevented. It's kind of hard to prove the counterfactual. But if we can democratize that to those who don't have a sophisticated IT infrastructure with Epic that can measure PROMs, like that's a small minority of surgeons. But if we can make PROMs so in your face that we're using them, that's the goal of what we're trying to build.
And so to clarify, you said that 100% of primary care physicians were using the PROMs to help decide to refer to orthopedics. Was that like anyone at Henry Ford who's like a PCP was?
No, that was just in our orthopedic department. And again, it's only a small subset. Like, we have, a handful of primary care sports physicians. Mm. But a lot of patients will come in and say, I've got this meniscus tear. I need to see a surgeon, right? And as a primary care physician, there's not a lot of recourse to push back. And the docs know, or the clinicians know that the patient doesn't need a surgery. But it's hard because the MRI is saying they have an extruded, degenerative, complex, multi-directional meniscus tear, and the patient's getting nervous. But with PROMs, the provider can say, look, you have this tear, but your function is normal. Pain is only mildly elevated. You'll probably do, and we've actually published thresholds of if you're under a certain range for function or over a certain range for pain, you will do well with surgery, and vice versa. You won't do well with surgery. So now we actually have cutoffs that say you will probably not do well with surgery. So getting that information out there, engaging the patient and the provider, both of them, that's where you kind of change thinking. So we are at Henry Ford to try to get PROMs into our fabric of primary care. Primary care has always used PROMs for like depression screening, right? That's been a cornerstone. And the key is just where can we use things like pain and functional scores for patients, not just musculoskeletal patients, but heart failure or maternal health, right? This is not unique to just orthopedics.
And so this index that you've built, let's say for orthopedics to kind of give guidance on like thresholds for maybe whether or not they would benefit from surgery, for example, if there were other health systems who've kind of reached out saying, hey, we'd love to be able to kind of access and leverage this sort of index or database you've built, is that still relevant for other systems, or would you say, you know what, like we can help you learn how to do it, but you really need to build your own regional data set for it to be relevant to your population? Like, how do you think about the relevance of your data set and sharing that potentially with other health systems in different places?
Well, we published our findings with the cutoff points, and others have done so with joint placement. There's a group that published their findings in back and spine surgery with the ODI form. So you can actually plug in the data points from these questionnaires and data points on a web tool, and actually will tell you % success in surgery. I think one of my big gripes with PROMs to date is that we haven't done that research, right? Like we have these tools and we don't know, there's been some research out there, but not a lot on what is a reference population, right? For a young, let's say a patient who's a 35-year-old Black female versus a 65-year-old white male, right? Or whatever, what is a normal score, right?
Right.
Because what we think of as normal ranges they're not age or gender or demographic matched, right? And so we haven't done that research yet. And I think that's been a huge failure. And that's part because we don't collect these tools and apply them. So I think we're only scratching the surface and there's a lot of debate on how do we use PROMs for individual clinical decision-making. That's not straightforward, nor is it really super well validated. We have thresholds that we look at, but we as a field have not done that. And I think that is what next needs to be done. But I'm still not seeing a lot of research. We did a study on PROMIS, physical function and upper extremity function on college athletes, like literally Division 1, 2, 3 athletes. And the reference score is very different. Now we know that these tools are calibrated with 40-year-olds, but like we should probably know what a normal function score is for an 18-year-old athlete, right? I mean, we should know these things so we can make better decisions. So if they have a normal score on a meniscus tear, but it's really 10 points lower because they're an athlete, we need to know that. And I think that's got to happen.
Fascinating.
Great point. So Eric, I want to shift gears a little bit, but I do think this question might come back full circle to PROs, but you wrote a great article in Harvard Business Review a few years back around the 3 myths of machine learning in healthcare. The myths were that ML can replace docs, 2, big data and data scientists will guarantee success. That's a myth. And 3, successful algorithms will be adopted and utilized. I'm wondering can you unpack the reality behind these myths?
I'm laughing because I haven't thought about that paper for a while. And I think it was like, I don't know, when was it, 16, 17? I don't know.
I think 2017. Yeah.
And it's funny because all this stuff and then media in the last, or chat GPT, all that stuff in the last month and it passed an exam that's rooted in textbook data. It's not hard to like that's. And so I think that like the question of AI and ML aside, it's funny that it's now becoming very relevant. And so I think where founders struggle, right? And Josh, this is no knock on you because I know you finished med school, but I don't know if you lived the painful existence of a practicing physician dealing with workflows and stresses there, but you probably have a very good appreciation for it. But like, I think some founders who don't have that appreciation will come up with a great tool that's got a lot of bells and whistles and it doesn't integrate, right? And it doesn't integrate not only from a tech stack perspective, but like from a workflow perspective. You can have a tool that integrates perfectly in the EMR, but if the physician doesn't know it's there, or it relies on any external thing, you're in trouble. I saw something online where someone was asking how come, apps aren't used as much for clinicians as they are on the EMR, because people are on the EMR slogging away, trying to get the documentation, and they're not on the EMR to discover. They just want to put it in so they can bill and document, right? And I think that developing technologies without that clinical understanding of the workflow, not how do you treat a patient with COPD or how do you treat a patient who's crashing with a heart issue. It's how do you bill? How do you put a code in? How do you, like for us at Protera now, everything I do is like, well, would a physician or surgeon use this? Yeah. And if so, why wouldn't they use it? And the reason why they wouldn't use it is overpowering. It's almost like, and I think that article really harped on the fact that and nothing's changed, right? You go to ChatGPT and ask them some stuff, nothing's clinically relevant enough to use in real time, like nothing. And I think I saw an article today where like Bing is having trouble now with ChatGPT integration, like even for day-to-day stuff, right? AI takes what we've done and spits it back to us in different ways. It's fancy regressions, all that stuff. And I think that like, the tech alone is not going to do it. In more startup founders, I bet, and Josh, and Alan, you may have experienced this too. Like the people who are successful have these like really probably shoddy MVPs that are horrible, but they get to the patient part of it. And the other thing about healthcare, my sister is a clinical informaticist at the Mayo Clinic, and she's part of our team at Protera. She talked to us a lot about this and says, you cannot just make a Twitter for healthcare. It is a human to human interaction, right? And there are expectations of healthcare as a patient that you're not going to pay for everything, right? It doesn't matter what the values. Patients want more expensive stuff because they're paying for insurance, because they're not paying the bill, and neither the physicians, right? In some ways, neither the hospitals. And so I think not understanding those things are going to be critical flaws for founders. And we're trying to avoid that as much as we can.
I totally agree. I think one of the things that I've learned, even though I haven't lived the full cycle of a practicing clinician, but I think I built that humility around kind of limitations of technology in healthcare. And so I think what I believe now is technology is a great tool, but it's not enough alone to drive transformation. In fact, the more important thing is change management. So technology is easy. The change management, the human piece is far harder, to your point. And so whenever I talk to people who ask me, well, Josh, what is seamless and these differentiators in the market and all that? And, investors want to hear some fancy thing like effect, AI. And that stuff doesn't matter, right?
It doesn't matter at all.
They're what's gonna reduce friction to adoption by clinicians? And it's things like you said, EHR integration. It's clinical evidence that you have confidence that this works. It's things that fit my workflow.
Well, here's an anecdote that sums it up. And so there's a primary care physician who has sent me patients since I started practice almost 7 years ago. He's been wonderful. And I had talked about some of the stuff we're doing in Protera. And I was asking him when you do make referrals, is it in the EMR? He's part of Epic. He's part of our system. And he's like, oh, no, I just ask the MA. She helps me. And it just shows you it's a total bypass of technology, right? There's no order, there's no integration. His staff does it for him, which is fine. But that's how a lot of people work. They have their staff helps them. They're not putting the order, they're bouncing around seeing patients. And if you don't understand that, your integration will not help. And I think, and Josh, you saw it enough in your primary care clinics and on the wards and the ICUs and the ERs. So you saw it. But if you don't think of that first and center, that just blew my mind. I was like, I've known this doc for 7 years, and I still blind because a lot of people put orders in the computer. And we were going around and talking to docs about Protera a little bit, and I was like, you can text us. Oh no, you got to put an order in. So it's just that philosophy that it's got to be workflow driven, and it's not the same for everybody.
Yeah, and thinking that you could just reinvent entire workflows for incredibly busy clinicians you just can't.
It's crazy.
You have to collaborate with the existing workflows for sure.
I'm always impressed when there is a startup that has no clinicians on the team. I'm like, how do they do this? I admire them because we're trying to aspire to that. And it's impressive because even getting an audience, if I stop by a physician's office as an orthopedic surgeon, I feel perfectly comfortable saying, can I talk to one of the docs in the office and talk to them about whatever I'm doing? I did that when we were starting in practice. When I was starting in practice, I was going door to door. I was giving talks at baseball facilities. I was giving talks at primary care clinics, physical therapy. I was sales, right? We were starting elective practice. And it's so much easier for me to talk to clinicians because I'm living the same pain. And to have a surgeon who's trying to improve value-based care and decrease the number of surgery we do, it's a compelling value proposal.
The funny thing is the innovators who don't have clinical experience, the good thing is that you are way more naive, meaning that if you were clinical, more often than not, you're like, no, this is not going to work. What's the point in trying to fix things? No one's listening to me. But when you're not in healthcare, you're like, oh no, listen to me.
Of course I'll change that. Of course. And it's funny is I hear about startups that are like, yeah, we can improve billing. You find me a physician, a primary care physician that don't care about billing and revenue. They're there, but they're a certain subset, right? You can't say that every physician cares. And the ones who care about the billing are really fascinated with the business side of medicine. And I love that, right? They're trying to figure out how to be efficient, how to be operational, I think maximizing revenue is important. I really do. So I bond well with them, but a lot of physicians don't care. Whatever. But some say you guys keep the billing. I'm like, that's not how it works, but fine. But a lot of people just don't care. And that understanding of that lack of understanding that not everyone is driven by by one incentive can also be very devastating.
100%. That's a fantastic point. Actually, just curious. So now that you've been on both sides of the table, if you were to give advice to some of these non-clinical entrepreneurs, innovators who are trying to reach out to people in healthcare to get their attention, and let's say they were to send you a cold email, what would you advise? What's the best way to break through the noise if you're trying to, land a meeting with someone like yourself?
Yeah. The big question is, what justification do you have that you think the system is broken, that you can fix it. And it's not to mean that it's not the case, right? But like, it's like when I was doing Physiolife as a resident, I didn't know the system was broken and I didn't know how to fix it, even though I was an orthopedic surgery resident. Now I have a little different vantage point because I've been living in it. And so if you're a 25-year-old founder trying to fix healthcare, you better have a very good justification to know that you're onto something. And I'm not saying you're not, but it would be helpful if you had a, like, why not have a clinician or a subject matter expert or a health plan leader or whatever? Like, why not have somebody on the team that's helping you make these goals? If an orthopedic surgeon called me or a healthcare leader called me, I'm going to answer the phone. But if it's a 25-year-old that's saying that I know how you can, I don't know, do whatever, like, I'll talk to them now because I'm more sympathetic. But like, I'm going to first be asking, like, how do you know this is relevant? Because even I don't know what's relevant in my own field and I'm struggling with it. So how do you know what's relevant and what background do you have that makes it relevant? Then I'll listen to you, or at least then I'll push forward what you're trying to do.
I think that's one of like the most fascinating things I've learned about like the healthcare technology world or healthcare in general when it comes to these sorts of relationships with like industry and clinical. In any other like industry, it's so common for like, let's call it vendors or companies to be on stage teaching each other things. But in healthcare, like that's a no-no. In healthcare, you want clinicians being on stage describing the innovations because no one trusts vendors. It's such a different world. And I think your point is really valid. You want to hear from your peers who you trust.
Yeah. And, I'm shifting my conferences that I go to now because it used to be only orthopedic. Now it's variable because, what we're doing, the health system and Protera. And it's funny, like I know people have the booths and they've got the vendor tags. I think we've talked about this, Josh. And if you're a clinician navigating among the masses, the networking and the warm leads, look, they don't all pan out, but like the warm leads are like, when I give a talk about PROMs, I don't talk about Protera, but people come up to me and then Protera comes up, right? And so being a subject matter expert or having somebody on your team, that CMO or whatever, chief strategy officer, like I am always impressed with companies who don't have that. I don't know. That's Herculean that you can accomplish this without it, because your life would probably be easier if you had a real bona fide subject matter expert that's on the team. And maybe it's hard to find them, but I think physicians are much more open to those things now.
Spurge, I think I heard a stat a couple of years ago that I think a third or something of Stanford's like graduating medical school class is not practicing clinically or chooses to work for a startup or something else. So it's definitely changing. It's definitely changing.
That's the other end of the spectrum.
Oh, yeah.
At Harvard, after I left, I think there was all these protests, and it is our policy, like you can't take a pen from pharma. So or any industry company, you can't take a pen, a dinner, nothing like that. And I see a lot of merit in that rule because there is conflict of interest. Unless you take a pen from every company, right? Like you're gonna like orthopedics is very prevalent. We're in the news all the time about this kind of stuff. It just is what it is. And so, yeah, I think that it's a very different philosophy. I think Stanford is on one extreme. And I think there's a few others like that, but they're definitely on one extreme. And I like it. I think it's great. Self-selecting.
Yeah, that's great. So, Eric, I wanted to get your thoughts on this just because you've been pitched probably thousands of times on all these different innovations. I'm really curious, given the digital transformation and innovation that's come about in the past 5 years, at least there's clearly this explosion of different innovations, everything from chatbots and remote patient monitoring and digital care journeys. What are you most excited about today?
I think that it's daunting as well, but I think the shift of risk to providers, I think that, health plans, and I'm talking to a lot of them now, health plans, I've always thought they're the ones that were, in the best position to manage risk, but really it's the physicians, it's the providers, right? And I think this shift of risk to providers is daunting because we don't have the tools, right? That's why these companies are coming about. And adopting solutions or point solutions or tech integrations is really hard to do. So we have these providers that are in big systems that are taking more risk, but are not in nimble situations. That's why I love Henry Ford, because Henry Ford is an academic institution, level 1 trauma center, integrated health system, but we have our own health plan. We have an ACO. We have an employee population with 20,000 employees at risk under our health plan. We have Medicare Advantage. We have risk-bearing contracts with the big employers. And so I think when you can go to an institution where you can really innovate around that, and we've done that as a system, we've taken some big risks on bundle payments and other types of work. So I think that it breeds the innovation that we never would have had right? I have a lot of friends in big systems, big academic systems that are 99% fee for service, right? They don't have that pressure to innovate. And so with this risk shifting and what COVID taught us, I think that's the most exciting time. So the extent to which these tools can help, right? At my business school reunion a little while ago, we talked about the chatbot for, I think it was Amtrak, and how they did a really good job because the Amtrak chatbot presented itself as a chatbot. And the customer could interact with it knowing it's a chatbot and it could limit its questions. I sold my car on Carvana before everything kind of hit the fan a few months ago. And I was talking to a chatbot for 2 weeks. I had no idea. And so I think that if you can we're talking about like drop-offs and this stuff. And then at the end, it was a he, I think his name was something. He was like, okay, let me get a human on. I was like, wait a second here. Like, this is just blew my mind. It's been 2 weeks. But I think that that's what ChatGPT is about, right? Like, can you operationalize and automate the mundane task of like, we still have call centers. Why? That doesn't mean like we have tons of people employed in call centers across the country, like tens of thousands of jobs and with a workforce shortage, those folks should be put somewhere else and we should automate that process. Like Open Table's been out for a while. Like the secret's out that you could do this and we haven't figured out how to do that. And we're starting to, there's another part of innovation at N4, the self-scheduling, and it's not just us. The key is, can you self-schedule the right patient, the right provider, right? And I think that'll be the next step. But these are the kind of things that are ripe for innovation.
Well, one of the fascinating things to me is that like medicine and healthcare might be one of the few places where the consumer, the patient, doesn't want to be talking to a virtual avatar or AI. Maybe like the operational things like the call centers, they don't mind doing that, but the actual clinical care, I don't think patients would feel comfortable doing that. But in any other like industry or use case, like call centers, airlines, banking even, you're happy to talk to a chatbot if it's faster. But not in medicine. You actually want to know that this is not just an avatar. It's a real person.
The other thing that's amazing is that like people aren't paying for it. Like most people on insurance, like they're paying for it through insurance. So if you look at a patient with end-stage knee arthritis, right, they're in pain 24/7, 365 days a year, non-stop pain. And a knee replacement, if you look at let's say an out-of-pocket cash cost, maybe $20,000, $25,000, $30,000 maybe. And we will go buy a Honda Accord for $30,000 that we will drive for 3 hours a week and have no problem paying cash, right? Or financing it. But the thought of paying for something that you will use 24/7, 60 seconds a minute, 60 minutes, whatever it is, like that philosophy. And again, we have insurance, and that's obviously a big part of it, but like the thought of paying for healthcare is really, really foreign. And the fact that we've tied healthcare to employers has been the most devastating thing because the employers don't have the tools to manage, and insurance companies get a percent. They're an ASO, like they get a percent of the claims or whatever it is. So the more money the employers spend, right, there's no recourse of payers to like really want to bring those costs down. So these are things, these economics are at stake, and patients have been on studies where they say, if I'm paying for insurance, I want the most expensive treatment possible. I don't care if it's any better than the other. I want the most expensive. So we have this weird situation, which is why the system is so fragmented and broken.
Scary and fascinating at the same time.
Yeah.
What she was like.
Really great point. It had me speechless, honestly. Eric, I wanted to ask you this. You've also been committed to giving back to the community in so many different ways. I know a lot of international service that you do in Dominican Republic and India, for example. Why is that particularly important to you?
First of all, I'm impressed you knew that. I don't even know how you knew that, but I guess, I don't know where that was from. Maybe some personal statement that's online. I would first say, I don't think I do nearly enough. I think that as physicians, at least from my perspective, we spend all of our time toiling away and sacrificing personal gain, and all of our buddies out hanging out and partying, and we're studying. And I think once we get to be physicians, we get caught in that rat race of work and starting families. So I don't think I do nearly enough. And I think that that's something I need to be better at. What's fascinating about going abroad and doing surgery abroad is that when I was a chief resident, I went to India, and we operated on a farming community in the Gujarat. And you would do the same surgery there you do here. We did rotator cuffs, tennis elbow, fractures, osteotomies, whatever it was. And we're talking about like Tylenol for 2 days. These guys are back out. Like it's, you learn that like we are a victim of our own doing. This pain as a vital sign thing put us back decades. As a resident, if a patient was in 2 out of 10 pain, 5 hours after knee replacement, we had to push morphine, right? Okay. Because the nurses' bonuses were affected by it. If their pain scores were up too high, this was 2000, whatever, 10 to 15. We did that to ourselves. And so I think going abroad, learning what you can do with less and the satisfaction that patients get from just being heard and being taken care of, it grounds you very much. But I have a long way to go in philanthropy and a lot more work to do. I don't think I do nearly enough.
Awesome. So humble. All right, just being mindful of your time, Eric, let's flip over to the Fast 5 lightning round. There's 5 questions to get to know you better for our audience. Number 1 is, what is your favorite book or book you've gifted the most?
The Obstacle is the Way, Ryan Holiday.
Nice. Yeah, I love that.
My surgery mentor from residency told me about it. And when I see kids with ACL tears and they think the world's going to end for them, I tell them about this book. And they'll come back and say, I read it. And you have no idea what life has in store. And if you adopt that philosophy of what that book teaches, it really makes it, apart from very tragic and horrible circumstances, it helps you kind of just keep pushing forward. Like, oh, didn't work. Jocko Willink, right? His thing online, it just says good, right? No matter what, it's just good. Move on. And so I think that book I think about that book all the time. And as a new surgeon, when you have a complication or something breaks nowhere, you're like, oh boy, nope, this had to happen so I can be better. And so you just, it changes everything. So that would be the book.
Yeah, I love it. Question 2, who is a person either dead or alive you'd love to meet?
Abraham Lincoln. My kid's 4. He's got Abraham Lincoln posted on the wall. My wife wouldn't let me name the second one Abraham, but he's fascinating. And for him, it's about grit, perseverance, but leadership, right? There's a book, Lincoln on Leadership, came out a long time ago. That's huge. And I'm not saying I espouse all of it. I mean, I live up to all of it. I certainly try to do as much as I can, but that book, anyone who's gonna be a leader or wants to be a leader, personal life, professional life, that book, study Lincoln. And that was Ken Yamaguchi, a shoulder surgeon. He got me onto all that.
Great. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
The minds. I'm sure, I don't know, you probably get that a lot, but I could be a lot better at that. That would help me a lot. So I think I'm especially bad at that. So if I can even get that a little better, it would have a lot of windfall.
I like that. The superpower is just 1% of being able to read people's minds. That's good. Question 4, what is something in healthcare you believe that others might find insane?
We can protocol care a lot and we can predict who's going to do well. Maybe this is more orthopedic focused, but like healthcare, I mean, we all know this, it's pattern recognition, right? We just got to figure out how to protocol that and automate that in a way that's patient friendly and patient engaging. But I think we could do that.
I love that. Question 5, if you could travel back in time to any event or moment, what would it be and why?
The Revolutionary War period fascinates me. I'm too much of a wuss to say I would want to fight in the front lines with musket fire, but like fly on the wall would be kind of cool. So I think that would be that part of U.S. history is always fascinating to me.
I love that. Surprise question 6 that I have, Eric. I'm curious, how do you maintain your optimism? Because I know you're wearing the Lions uniform today, and they haven't won since '57. So what keeps you going?
So I got really into football when I was in Boston. I was there for 9 years. And so lots of parades. I mean, so many parades. I remember my OBGYN clerkship. I missed one day. I played hooky because I went to the Celtics parade and I came back. There's green confetti everywhere. And so championships were very used to, like, that was just, there's another one. I lived in on Common right in Kenmore. What's funny is I've been with the Lions for 5 years. And, you know, I always, in the beginning, was like, how are the fans so rabid about this team when they've had this record? And seeing over the last few years, like, my wife asked me, she's like, you don't care about the Super Bowl anymore. I'm like, I don't care. It's like, well, when would you care? I was like, if the Lions were in it. And I was like, oh my God, it happened. I am now on that side. And so I think part of it is just being part of the organization, all the changes they've had recently. I mean, they're at the top of the town now. The staff there and you know, as medical docs, we're kind of, you know, we have our own little side there. We're not like core to any sort of athletic part of it, except for taking care of the players. But like, but it's kind of phenomenal and it's kind of neat. Anytime I'm on a game watching from the sidelines, I'm always like, well, this was my dream to do this. And it's kind of wild that the players are like, I'm bumping into them, they're bumping into me. I'm the guy who usually goes on the golf cart to take the guy to the X-ray, and so my job is just not to fall off like on TV or whatever it is. So, and so I think that being part of it and seeing it and like you're really part of the organization, I think that's why I crossed over.
So cool. Well, that's amazing. Eric, I want to thank you for coming on the show today. You've sprinkled so much wisdom. I hope that some of the audience out there has really understood what you were talking about with PROMs and can maybe incorporate that into a seamless workflow that's invisible in their own practice. You can find Eric on Twitter at Eric Makhni, MD. That's ERICMAKHNIMD. And that's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, you can visit www.seamless.md. Eric, Dr. Makhni, again, thank you so much.
Thanks so much for having me.